nothing else. All right, let's get started. So we'll be doing second part of interpreting X-rays and in the musculoskeletal practice. So today's learning objectives. Hopefully by the end of the lecture, you will be able to interpret X-rays in your clinical setting, explore the variations of the types of X-rays possible, the clinical decision making that is involved to discuss, and decide if you do need to approach for X-rays or not, and what can you see under X-ray? Is it just the bone, just the cartilage, just the soft tissues? What else can you actually see? Then certainly there would be different views, what is important for you to view at, and then how you should systematically read X-rays rather than go in a hodgepodge, haphazard manner. Lastly, this is extremely important, and this is probably what you are looking for, is I hope that there will be about 6 or 7 joints that we will be discussing, normal versus pathological X-rays of that specific joint, to understand what you can see normally and what you can see, diagnostic features in certain cases or scenarios. So what to expect today? I always tell that initially that this is essentially a content of a book. When you open a new book, you always go to the content and see what is there for me inside the book that is important for me. So this is essentially what to expect today. Is we'll go over a brief overview from the very first basics of X-ray, which Dr. Imran has already shared with you in my YouTube channel. If not, please go back to that YouTube channel and go over that part 1 or the basics of X-ray. That is extremely important. That's a foundational knowledge before you jump into part 2. Don't forget to subscribe. It's a new YouTube channel. I'm trying to develop more content oriented for professionals like you and me to help improve the boundaries and the horizons of knowledge. And then we'll do a little bit of decision making based on current research scenarios. Then we'll do some reviews. Ultimately, we'll go overview of chiropractic spinal evaluation. Again, don't think that chiropractic spinal evaluation, that content that I will be talking today is about that this much, like 10-15 minutes. It's a whole semester long program, how you can interpret chiropractically in terms of X-rays of the spine, of other joints, and how you can mathematically compute certain geometrical differences or analysis. We'll touch upon a little bit as to how we can measure certain, based on chiropractic evaluatory methods, how you can measure the differences between certain bone edges in the spine, obviously. Then we'll try to interpret certain joints between abnormal and pathological. We'll do certain inferences from those X-rays. And at the end, the question answer session is for you to ask me questions, and hopefully I can satisfy to the best of my abilities. So overview, again, typical long bone, you all know, I understand. Follow my mouse or cursor to what I am saying. That will actually help you hear me out, see the content, and try to register in your gray cells. All right, so over here is basically a long bone, a generic long bone. Here in the middle is the diaphysis or diaphysis. In the middle is your metaphysis. Metaphysis can be proximal as well as distal metaphysis. And at the end, we all know is epiphysis or growth plate, epiphyseal plate, growth plate, right over here, which is the proximal part. And you have the distal epiphysis. But for us, it is also important to notice that this outer layer is called periosteum. Then we have an inner layer called endosteum. In between, now my cursor is moving from the left to the right. Left long bone to the right side, right over here, which I am showing as the cortical bone. Where do you have cortical or very hard bone that you can actually see clearly visible under X-rays? This is the periosteum, and this probably is your endosteum. The layer that is filled between periosteum and endosteum is called cortical and hard bone. Whereas inside the endosteum, inside, but inside that layer of endosteum is this guy, which essentially is nothing but your cancellous bone, spongy bone, trabecular bone. Remember one thing, this spongy bone, trabecular bone and cancellous bone is mostly at the ends of the long bone. So it could be proximally directed or distally present. The middle of the diaphysis is nothing but bone marrow. Right over here where I'm pointing my cursor or mouse is bone marrow, is in the center where you have a Haversian system, right? Haversian system, which is essentially a network of blood vessels, which gives the nutrition to stem cells, to new cells that is being generated, and also equalizing osteoclastic and osteoblastic activity. So again, full circle, what is important for you to understand from here, from this slide? Epiphysis, metaphysis, diaphysis. At the end, in the epiphyseal structure, you have spongy bone or cancellous bone or trabecular bone. Trabeculae is nothing but this spider web pattern, as you can see right over here, the spider web pattern. This spider web pattern is essentially trabecular bone. What is inside on the superior, above the, just below periosteum and above endosteum, in between, our cortical bone or hard bone is our cortical bone or hard bone, and then in the middle is our your bone marrow, where you have that diaphysis right over here. Okay, so then we go over basically the color coding aspect of X-rays. So on the left, I'll focus my discussion initially right on the left hand side. As deeper, so essentially X-ray is not a color picture. Just pure X-ray is shades of gray. Too much of gray can be black. The less gray that you have will be lighter color or whitish in color. So if there is nothing inside, it's air, that will be black or dark. And if there is a metal inside, then it will be completely white. And in between black and white, is soft tissues, a deeper gray, to bone, a lighter gray. And in between that middle gray point is your fluids. Fluids is extremely important, especially if you are taking lumbar spine or pelvic X-rays. You can actually see gas in the abdomen. You can see if the bladder is filled or not. You can see if someone is constipated or has basically poop in their rectum, right? You can actually see that. So this essentially comes under shades of gray or fluid. Now this is a very, very beautiful picture on your right, where you have, this basically helps me understand or memorize that I essentially never forget this picture. This helps me decipher if I am confused with an X-ray. I just remember this picture and it helps me understand what I am looking for. So initially what I am looking for is basically right over here is air, and air is darker in color. Soft tissues, which obviously you can understand this is nothing but fracture of a tibia and a fibula right over here. An open cut or an open wound, which probably if you are not working in trauma, you will not be able to see. I usually don't work in trauma. That's not my specialty. My specialty is chronic pain. So I don't deal with these kind of issues or, open wounds. But if you do, if you are in acute care setting, then probably you can see these kind of patients. Now, what I'm trying to evaluate is when it is light gray in color, it's essentially soft tissues. Now you have bone. Now the beautiful part is this whitish area is the cortical bone, which is right at the edge of the bone, long bones or vertebra or pelvis. The edge, the covering of every bone is very, very thick, hard cortical bone. That's why it's pretty white in color. And in between, in the middle, you might have bone marrow, or you might have the trabecular bone or cancellous bone or spongy bone, which is of a darker shade. Right here is your cancellous bone. And at the end, if someone has an implant, that could be a plate, or that could be like an implant, like a total arthroplasty, knee arthroplasty or hip arthroplasty, even shoulder or elbow. You can easily see those implants right over here, and they are completely white in color. All right, fantastic. So decision-making considerations. So do you need to check x-rays? Do you need to order one x-ray or not? I don't want just to spend my patient's money. It is not ethical, neither it is imperative in my diagnosis. It is a first order diagnostic imaging, as it's saying, but for that, patient needs to spend money. If I am able to do my evaluation and come to a conclusive evidence from history taking, from special tests, from other orthopedic tests and other diagnostic measures, then I don't need to do that, any radiographs. But if you do need to, then you should need at least two views. The two views should be 90 degrees to each other, 90 degrees to each other, like APPA view and a lateral mediolateral view. APPA and mediolateral are 90 degrees, like 90 degrees. So it has to be 90 degrees to each other. Remember, if you cannot see any abnormality in an APPA view or a lateral view, that does not mean it's not there. There are limitations on x-rays, and if you want to understand limitations, uses and everything, please go over to my YouTube channel. Dr. Imran has already sent you the link. Go over the basics of x-rays. I have described the advantages, disadvantages, uses, limitations, everything in that video content. All right, so what are algorithms to rule out the need for x-rays? Unfortunately, right at this point of time, there are only two: Canadian C-spine rules and Ottawa ankle rules. So what do you mean by that? So for cervical spine and for ankle, do you need to see x-rays or not? You can Google these two terminologies, this phrase or verb, and then you can search for that. These are nothing but essentially a questionnaire where you have history, where you have other, range of motion tests and other tests. Based off of those history, open-ended and closed-ended questions during history taking, based on your range of motion and other tests that you do, you can come to a conclusion if really x-ray is needed or not, if really x-ray is needed or not for cervical spine. But this Canadian C-spine rules, please remember, is valid for traumatic C-spine, like road traffic accident and an individual went for a whiplash. Then there are certain considerations that trauma surgeons or physicians in the emergency room, they do to see if there is a need for radiograph, yes or no. Exactly similar to the C-spine is your ankle joint. And it is very, very straightforward flow chart that you can Google it and basically know if your radiograph is involved. Now you can ask me, okay, you have given C-spine and ankle. What are the rest? Well, unfortunately, there are none till today or till last night. So till now, we have only two sets of rules. One for the cervical spine or neck, that is for acute injury or road traffic accident where someone went through a whiplash. And then we have some ankle rules too. All right, variations of x-rays. Now, obviously, in the first go, you can certainly go in to do simple x-rays. Like simple x-rays, go to a radio diagnostic center, get some images done. But it may not tell you the entire story or the whole story. So there is something called video fluoroscopy. So in our lab in US, I am a kinematic shoulder research scientist. So in our lab, we have video where we have biplanar x-ray. So two x-rays pointing at the same joint. And when you do those motions, you can actually see the motion or movement in real time, what's going on inside the joint. That is really cool to see a biplanar x-ray fluoroscopy and see the motions real time in a computer monitor, how basically any joint is moving. And I do kinematic, or I used to do kinematic analysis based on video fluoroscopy. Now, then you have arthrography. Obviously, you know that there is a contrast medium involved. Surgeons or physicians basically do some, injections of the intra-articular with dyes, and they basically try to evaluate the health of the joint before arthroscopic surgery. Then you have myelography, and then you have discography. Now, myelography is rarely used right now because there are lots and lots of side effects or limitations. You can go online and check, but discography is certainly still done, especially done by spine surgeons before any spine surgery to check the health of the disc. But you know, with time, with the advancement in X-rays, with the advancement in MRI and CT scan, less and less contrast medium is being used, because as you are inducing or introducing dyes, obviously it has some side effects that you don't want your patients to basically have any kind of, you know, anomalies or problems later on in life. All right, this is again a review from the basic X-rays, which is there in my YouTube channel, and you should go and take a look. So systematic review. I am a huge proponent of systematic review. Don't do a reading hodgepodge. You may understand, you may not understand everything in total. It is always, you should have a set rule in your own mind that, okay, step by step, I need to advance reading the X-rays according to what I think justified. That will help my conclusion. That will give my understanding or better judgment to understand the diagnosis from clinical standpoint after reading the X-rays. So first is orientation. So is it displaying the correct structure it is supposed to display? Viewing the series, usually it's AP, PA together. It is not just AP after than PA. If it's either it's AP and then lateral or PA then lateral. So AP, PA is usually together, okay? Then lateral, then oblique, and certainly there are special X-rays or radiographs that you can take or you can order for individuals. Let's say there is hangman's fracture, where the odontoid process is basically broken down and then it is impinging on the medulla oblongata or of the spinal cord or the breathing center. Hangman's fracture. So for that, you have to make the mouth open, right? Open and basically do an X-ray base, keep the mouth open, and you know, it's a PEG X-ray. It's called the PEG X-ray, where you can have to open the mouth and have a better view of C1, C2, and a little bit above and a little bit below to have a correct diagnosis. Then steps to evaluate. Oh, this is one of the most, this is not end all be all. Like, there are many different types of evaluative measures, but to me, this is a very basic, simplified, and easy to go through. And I still do this way actually, because it's just simple. And what I do, this completely serves the purpose what I do in terms of clinical practice and research. So ABCs. ABCs is basically A for alignment and appearance. If the alignment of two joints, how it is supposed to be. If the, let's say if it's an elbow joint, the alignment should not be straight from the, you know, shaft of the humerus to the shaft of the radius and ulna of the forearm. No, there has to be an angle called the carrying angle, like this. There has to be an angle. So you need to have your anatomy and biomechanics extremely, extremely thorough before you read X-rays to understand how the bones are angulated or oriented. So for example, carrying angle of the elbow versus in your hip joint, you have, you know, coxa vara and coxa valga. There is always an angulation, a normal angle, neck femur angle, right? Neck femur angle of about 120 degrees, 110 to 120 degrees. That is normal, right? So those are the angles that you need to take care of to before you see that and evaluate the X-rays. So that's alignment. Appearance. Oh, okay, appearance. Is the bone looking how it should look? Is there any kind of discrepancy on the margins? Is there any discrepancy on the center of the bone or on the thickness of the bone? So you need to evaluate those. You need to evaluate those you know, variables to basically check if there are any kind of anomaly or not. Then obviously very, very important, if you are checking an X-ray of an athlete with injury or geriatric or senior citizens for bone density. Just a reminder, please mute your mic and your video. Someone has their mic still on. So I really dislike that repeatedly saying this. So please respect what I just said and check your mic double time. All right, so alignment and appearance. Then you go in for bone density. You check for if there is osteoporosis, osteopenia, or demineralization present or not. Please check overall the health of the bone. Then you check for cortex and cortical integrity or consistency. If there is a break in the cortex or not, if there is something that is abnormal to you in the cortex line or not, is there cortical thinning present or not, especially around the two joints. Very, very important. Please note down, I forgot to tell you, when you are in my webinar, I do not like to spoon feed. This content is basically there for you to read, but I will tell you a story, and with that story there will be a lot of information. So it would be recommended to write in a piece of paper so that it is there for you. Just don't think that, okay, I will upload it on YouTube, you will read through it and you will understand. People generally tend to forget, and I have been teaching for a long time in various parts of the world, so I think I know what I'm saying. So please try to note it down, and it would be better if you can ask me questions at the end of the during the Q&A session at the end of my talk. So we were talking about cortex. Take a look at the cortical layer, especially when two bones meet or at the joint. If there is too much of grinding, there will be cortical thinning present. So always take a look at that. And soft tissues. Now, soft tissues X-ray, it doesn't say much, and you're right, it does not say much. But if there is a tear or if there is fluid buildup, certainly you can see. If there is gas in the stomach, then you can see it in a pelvic X-ray or the lumbar X-ray or thoracolumbar X-ray. You can see. If there is urine collection in the bladder, fluid, certainly you can see. Soft tissues, again, in the soft tissues, if there is kind of tear or any kind of anomaly, abnormality, contusion present, then you can certainly at least get an idea. Something is not right. It will not give you the entire picture, but at least put your question mark in your mind to say, I think we need to check, evaluate hands-on palpation, or better MRI to do and check if there is any muscular or soft tissue tear or problem or pathology going on or not. So that's essentially ABCs. That's how one should read through, go over X-ray reading. Now, so this again helps you to understand how you would be reading a normal knee joint. This knee joint, supposedly in the book that I referred, is saying normal, but in my eyes, I don't think that this knee joint is a little bit normal. As you can read, it is displaying what is supposed to display. That's orientation. Okay, it should be a little bit tilted. Okay, it is, but it is missing side L. Remember, it is very, very important. Even though as an healthcare provider or a professional, okay, this is a left-sided knee joint because the fibula is on the lateral side, but it is still extremely logical for the radiologist technician to have an R or a L or some other letters imprinted in there, because you do not want to have even 0.01% of error. You might know, but you might also miss it. Why would you miss it, right? This is so important because we don't want to play with our patient's life. They are so important for us when we should respect that, right? So missing side L, for me, that is extremely important for orientation purpose. Views, obviously, you should read the AP view first and then go in for the lateral. Now, ABCs. Since it's a normal knee joint, well, we don't have much, but look at that right over here. The joint space for me needs to be more or less equal. But in here, the medial joint line is a little bit asymmetric. The space, I am not saying it's completely compressed here, right over here, but it is a little bit depressed. Can you see that? And I hope you would appreciate that. But in the book, it mentioned as normal knee joint. But in my eyes, I don't think it is normal. If it's just the AP view, then this right over here, this space should be close to symmetrical from towards the lateral joint space, also close to symmetrical, relatively symmetrical, if not completely symmetrical. I don't have to be completely symmetrical, but at least it needs to be relatively symmetrical. Now, going towards the lateral view. From the lateral view, you can see, look at this patella. It is pretty high, right? Right over here. and it's probably grinding towards the femoral condyle and related to, look at this very faint thick white line, and this is probably a sclerotic plaque of the cartilage. When the cartilage is kind of grinding for a long period of time, there would be, you know, thickening of that cartilage, abnormal or pathological thickening of that cartilage. And this is probably the case right over here, where you have a little bit of sclerotic plaque between the patella and the femur. All right, now when we come to a pathological knee joint and then read it systematically how it should be reading, orientation again missing, right? Is this left knee or right? This is actually a right knee because it doesn't say anything. What it should say is the right knee, but it doesn't say over here. This is not L, but it should be R or right knee. Obviously view AP first and then lateral and then ABCS. Now from AP, you can see, how do I know that this is misaligned or malaligned? You always take a look at the corner of the condyle. Is it matching the femoral condyle lateral? Is it matching with the tibial condyle lateral? The femoral condyle in the medial aspect, is it matching to the medial aspect of the tibial condyle? Are these 2 points in the same line? Are these 2 points in the same line? They are not. In fact, as you can notice, the tibial lateral condyle is little bit laterally pointing out, and the femoral medial lateral condyle is actually forced medially. So there is a misalignment or malalignment within the joint. Obviously, as you can note, there is good amount of bone density, and this very, very faint structure that or grayish or darkish color is saying, it actually is not osteoporosis. If the patient has osteoporosis, the darker colors are very pocket-like, like, you know, rounded structures. Like over here in one pocket, it will be dark. Right over here in another, it will be dark. But consistently overall, with such a smooth surface overall, is usually not the case. Now, how do I know this? Obviously, it can come as an experience, but rationally speaking, how do you know that this is not osteoporosis? Look at the beautiful joint line, right? There is no such, you know, much of osteophytic changes. It's just there are osteophytic changes, but not much to create this amount of osteoporosis. And it is consistently similar shade of gray. If someone has osteoporosis, it will be inconsistent shades of gray in pockets, because osteoporosis doesn't mean the entire bone is osteoporotic. If that happens, then the patient will never come to you. There will be fracture of that stress fracture or whatever, crack fracture or whatever types of, you know, problem or pathology. He or she will not be able to walk to your clinic and say, oh, I have this kind of picture. But to me, there are no pockets. It is completely consistent in terms, and it is beautifully in terms of, look at the trabecular lines. So such a beautiful trabecular line shows to me that it is not osteoporosis, or it is basically good. There are very, very minimal osteophytic changes right over here, There is cortical thinning right across the joint, very, very white sclerotic plaques present. That's why there is sclerotic changes. It's right where I am pointing. Sclerotic changes right across this area, especially right over here and a little bit over here, and right around this area there is sclerotic changes. Obviously, as you can note, the medial joint line compression is present. Okay, now, can you not find anything else? Probably you can, but do you essentially need to know all this or need to see all this? Once I know that there is medial joint line compression, there is sclerotic plaques present, and these 2 points and these 2 points over here are not matching, I know for sure it's a pathological knee. Probably it is either RA, any type of arthritic changes present within the knee joint. I don't need to go in depth into understanding each and every problem or pathology. Then probably my entire day will be gone by just reading one X-ray. That is not logical, that is not practical, and you will also not do it. You don't have time for that. All right, now when we are shifting to the lateral view right over here, It has good soft tissue. Look at the beautiful striations of biceps femoris, semitendinosus and membranosus right over here. You have the three hamstrings beautifully separated, right? You have the quadriceps, and probably this over here is the VMO. This is actually not the left knee but the right knee, right? Because this fibula is on the other side, as you can so notice. You have if the patella is at a higher place, but the soft tissues are pretty good, and the patella, since it's pretty high, look at that, high patella, so there would be patella rubbing on the femoral condyles, creating this very, very faint white sclerotic plaque, and probably this patient will have patellofemoral arthritis and pain during walking or climbing up and down stairs, especially down than up, right? Because that's where you have eccentric contraction of the quadriceps, pulls the patella high and grinds it more on the condyles of the femur. All right. So now, chiropractic spinal evaluation. What do I mean by that? Essentially, you have C-spine geometry and L-spine geometry. So what is C-spine geometry? I'm not sure if you have heard these terms or not. I do have pictures in the next slide. So please bear with me. And if you don't understand at the end of the talk, let me, raise your hand or ask a question at the end of the talk. All right, let's go ahead. So C-spine geometry. So this is basically called the ADI or Atlanto-dense interspace. So what is this interspace? It's essentially a C1 arch to odontoid process. So you take this is basically a lateral view of the spine. But this ADI, the better way of measuring ADI is a flexion view. How can you measure it? You can measure on the X-ray with a tape or a ruler. With a tape, like measuring tape or a ruler. What are you measuring? From the anterior body of the C1 arch to the odontoid process, tip of the odontoid process, wherever it's going or hitting, how much is the distance? And there are various, measurement protocols for that. I don't want to go into it in detail because it will be really advanced. So you have to measure that distance. If the distance is too much, if the distance is what is too much, over 5 millimeters, then probably there is transverse ligament laxity or rupture. Now, this is very important for me as an osteopath and a chiropractor. Why? With flexion and a lateral view, after measuring with the tape from the anterior tubercle of the arch of C1 to the odontoid process, if the measurement is over 5 millimeter, I know for sure that the transverse ligament is pathological. I will never do high velocities on C0, C1, C1, C2. I will repeat this one more time. Extremely important who does high velocity thrusts, right? Hopefully you don't just see YouTube videos and try doing it. It is extremely critical for you to understand the precursor to those techniques. They don't show you how they test it. They just do it and don't just go in and do it. There are protocols that every osteopath and chiropractor follows, and that's what this is one of that protocol or part of that protocol. So ADI space after you measure, and if it is less than 5 millimeter, then I do C0, C1, C1, C2 or high level, thrusts for the C spine. That could be for multiple reasons. But do I do this ADI every single time? No, I don't. There are there are 3 or 4 tests, but I do 2 tests, orthopedic special tests that I do to check the integrity of the transverse ligament. And obviously you will also take history. So you need to understand, and you will be checking for nystagmus and other neurological deficits. Is everything is intact? And if the patient does not have, or there is no opportunity for you to see that X-ray, then that's okay for you to do a high velocity after testing the integrity of the transverse ligaments. All right, then cervical gravity line. So it is the line between the center of the odontoid process to the anterior body of C7, right over here. Look at that. So this is the cervical gravity line. Right over here is the center of the odontoid process. Right, it drops towards the bottom of the X-ray or the X-ray plate or the radiographic plate. If this C7, this line should cross the anterior body of C7, anterior body of C7. If this line is forward, if this line is of C7, in front of C7, then there is forward head posture. So like this, if that odontoid process line from the X-ray, when you drop and it is in front, that line is in front of C7 right over here, rather than on the anterior body, the line is shifted anteriorly outside C7, then that head is forward posture. Then you have to do postural correction method or corrective measures. Okay, so this is a extremely nice quantified value that you can use as an outcome measure in either in your research or in your clinical practice to check if the head is forward posture. Now after your treatment, if the forward posture is actually obliterated or you have corrected the forward posture or not. This is beautiful way, quantifiable way to evaluate that. Okay, now one of my favorite, this is called basically the George's line or the posterior spinal line. What is George's or posterior spinal line? It is the line touching all the posterior vertebral bodies. So these are the vertebral bodies. Anterior is towards our left, posterior, that the spinous process is towards our right. So when I draw a line connecting the posterior vertebral body like this, it should match. All the posterior vertebral bodies should match. Again, it's a lateral view of any spine, of not any spine, sorry, but of the entire spine. You can do lateral view of the entire spine. You connect these dots from the posterior vertebral body, and that is called George's line. And what is the importance of George's line? If there is slippage of the vertebra, you know it is spondylolisthesis, and you can grade spondylolisthesis based on how much slippage there is of the superior vertebra relative to the inferior vertebra. Superior vertebra relative to the inferior vertebra, you can easily grade that. Okay, now why it is important? George's line, right behind the George's line, right over here is your spinal cord. So the spinal cord is actually running superior to inferior right behind the George's line. So that's why it is very critical, so that the vertebral body are all in the same line or same plane. Actually, it's not a straight plane, it's a curvilinear plane. It's a curvilinear plane. All right, second, what is this spinolaminar line? Spinolaminar line is a secondary check for vertebral alignment. Secondary check for vertebral alignment. And where is this spinolaminar line? Spinolaminar, as the word says, spinous process, the junction between the spinous process and the lamina of the spine, which is essentially the bone between the transverse process and the spinous process. That curvilinear bone, that junction between the spinous process and the lamina, if you draw a line across, that's called the spinolaminar line. You also need to check if this spinous process is crossing the spinolaminar line or not. That will help you understand if there is listhesis or not. And just, you know, this is, as I said, it's a 1 hour and we are close to 1 hour. But what I am trying to tell you is very basic. There are many other diagnostic principles based on George's and spinolaminar line, which is beyond the scope of today's webinar. It is not just listhesis. We can also discuss about, you know, disc bulge and disc herniations, and, you know, there are many other rotations in scoliosis and hyperkyphosis, also very important in George's line and spinolaminar line. So these two lines are extremely important, not just listhesis, but also scoliosis, hyperkyphosis, any kind of disc bulge, disc herniation too. And obviously, since the spinolaminar line is behind or posterior, so in front is your spinal cord. All right, good. Then we jump to lumbar spine geometry. Now, for lumbar spine geometry, you have lumbar gravity line. What is lumbar gravity line? Lumbar gravity line is nothing but from the center of L3. Let's go back. From the central vertebral body center of L3, a line is dropped, and if that line touches another line which is anterior of the sacral base, this is my sacral base. If I drop this line over here like this, and this line, you know, drop it and crosses at some point, this angulation is called lumbar gravity line. And what is the use of lumbar gravity line? Lumbar gravity line, if that line falls anterior to the sacral base, like over here, line falls anterior to the sacral base, then the weight bearing is anterior. Weight bearing. So the essentially the weight bearing or the individual is forward bent. Forward bent. That could be because of low back pain. That could be because of multiple other issues. And this is very, very evident in who? In pregnant mothers. Again, remember, you will not do an X-ray of the lumbopelvic area during pregnancy because it's an ionizing radiation. But if you have done, this is exactly what you would have seen. And in obese individuals, this is what you usually see, which is essentially similar to pregnancy, a forward body weight, and the individual, you know, goes forward or bends a little forward, and then this line falls anterior to the sacral base, and that is called anterior weight bearing. Now, again, this is not the only diagnosis. We can talk about pelvic nutation, counter nutations, and rotations based on lumbar gravity line. And there are measurements based on Gonstead methodologies and other Gonstead chiropractic methodologies, which is beyond, again, the scope of today's webinar. I mean, there are mathematical calculations for that. All right, again, if the line falls posterior to the sacral base, so example, this line right over here where my mouse is falling, if this line is behind 1/3 of the sacral base, right over here, then what does it mean? That means there is posterior weight bearing. So essentially the weight of the patient is like this, or the posture of the patient is like this. There is listing of the body posteriorly to prevent something. Again, since we are only talking about X-ray, I don't want to go into pathodiagnosis of X-ray and eventual diagnosis. That is not the purpose for today's webinar. So we'll stop at that and say, okay, if the line falls posterior to the sacral base, right over here, that means there is posterior weight bearing. Good. Lastly, lumbar spine geometry. It's called Ullmann's line. What is Ullmann's line or Ullmann's right? Ullmann's line is essentially the sacral base line perpendicular to L5 body. Sacral, I don't have the picture because it is a little complex to draw. Let's say if the sacral base line falls right over here in this direction, and there is another line from the anterior of the body that falls like this, and if that line is not perpendicular, then there is spondylolisthesis. Now, remember, George's line is a primary diagnostic feature for spondylolisthesis. Ullmann's line is the secondary diagnostic feature for listhesis, because Ullmann's line is extremely valid only for L5 and no other vertebra. I mean, you can do, but it is not valid. It is only valid for L4, L5, basically. Slippage of L4 on L5 or L5 on S1, you can do. Anything that is related to L5. So it could be one level up L4, one level down S1, essentially, or sacral base. So that slippage of that L5 vertebra, you can basically check with Ullmann's line. But my go-to, my personal preference is based on your George's line and spinolaminar line. Okay. So this is essentially what we talked about, our cervical gravity line, George's and spinolaminar line, and at the end, lumbar gravity line. All right. Now, again, this is more so like a chiropractic evaluation method based off a little bit of Gonstead involved in that. But we will not be doing Gonstead technique, because in Gonstead you have to mathematically, you know, evaluate rotational measures in degrees and millimeters. So we are not doing that. All right, so spinal stability evaluation, what is it essentially? So you are dividing, in a lateral view x-ray, you are dividing the entire segment of the spine in anterior, middle and posterior segment. Anterior is anterior body, posterior is the tip of the spinous process, middle, this line is in the posterior body, and this one is usually 1/3 of the posterior body from posterior section. 1/3 of the posterior of the vertebral body from the posterior section. So posterior column, middle column, anterior column. How would you know if the patient you are treating has a stable spine or not, right? It is so critical for you, because you don't want to damage spinal cord at the end of the day and make an individual, you know, like paraplegic, not even just paraplegic, any trauma to the nervous system, right? You don't want to do that. So to evaluate that, if there is disruption of 2 or more columns, if there is disruption of 2 or more columns, that results in an unstable fracture. So there could be, you know, spondylolisthesis, so spondylolysis or Scotty dog appearance, you know, right? Fracture of the lamina. So any case, in any fracture or trauma of the spinal segment, there would be some amount of slippage of the anterior body or posterior segment of the column of the spinous process somewhere in the body. If these columns are not like this, if these columns are not equal, all these 3 are in equal line, then 2 or more, then for sure there is instability, or the spinal segment is unstable. Better to refer to a spine surgeon or a concerned physician to recheck and re-evaluate. All right. Now, what are these dots? These dots are nothing but basically your spinolaminar line, your George's line, and your anterior vertebral body line. This is your anterior vertebral body line. All these dots or lines are symmetrical. They need to be as smooth as possible, like this. Then you know your patient has intact spinal curvature, intact bone, intact disc, intact height of vertebral body, intact height of, okay, and intact, possibly intact foraminal diameter, intact foraminal diameter, neural foraminal diameter, I mean. Now take a look at this x-ray to your right. Look at what is happening. This is dangerous, right? And we all know that there is slippage or listhesis of this fourth this is actually in the book, it is saying C4. So C4 slippage on the C5. Now, we all know this is listhesis, but the listhesis is so, the listhesis is so much, there is hardly anything that is left of C4 to be stable on C5. This actually will lead to subluxation and dislocation. Dislocation, we can't even think, because look at the spinal cord right over here. It will completely spool the spinal cord anteriorly, and the patient will be paraplegic. So this is an emergency situation where you can see the George's line, the spinolaminar line, the anterior vertebral body line, and none of these 3 lines are matching. The anterior, middle and posterior columns of these 4 segments with the lower segments are not even matching. You know this is not a good scenario for your patient. Emergency situation, refer to the concerned individual to either hospital or physician, whatever you deemed is necessary. Okay, so we talked about chiropractic evaluation, a little bit of Gonstead techniques in both, geometrical analysis of cervical gravity line to lumbar gravity line, and a spinal stability, again from Gonstead approach, but we obviously didn't do any measurements to check for stability of that spinal segment. Now we are coming into very specific type of, diagnosis that you come across. Osteoporosis under X-ray. So osteoporosis, as we all know, is essentially loss of bone mass, right? But does that mean that you always will be seeing osteoporosis and nothing else? Well, you can also see a little bit of osteopenia or even demineralization, where there is starting of bone mass that is being depleted. There will be breakdown of the trabecular bone, the canaliculi and the Haversian system. There will be breakdown of those that you can, it is evident under X-ray if you have a keen eye. So X-ray view, how will you view this osteoporosis? As it is the shade of dark or black, and the more osteoporotic the bone is, more pockets of dark, right over here is dark, then white, again dark, right over here is white, then dark, again white, again dark. So you will see there will be pockets of white and dark and shades of gray, light and dark and black and white and these. So this now makes you understand that probably is demineralization and is osteopenia or osteoporosis. Now this next point is extremely important. Focus. Features. Reduced bone density does not mean that all reduced bone density will be seen under X-rays. You need at least 30 to 50% reduction in bone mass to see it, to recognize it in under radiograph. So if the reduction of bone mass is about 10%, 15%, maybe 20% according to research articles, then you will not be able to evaluate or see actually if there is any osteopenia, osteoporosis present in the X-ray of the joint that you are taking. Okay, does not mean all other joints are good. It's just, let's say if you are checking knee joint and one knee joint is good, does not mean the hip joint is not osteoporotic or has arthritis, because that will vary and that might vary. Okay, all right. There will be loss of trabecular. I told you what is trabecular. Trabecular is cancellous or spongy bone, cancellous or spongy bone. And but as I said earlier, will be pockets of dark and white remaining trabecular. So some parts will be gone, the trabecular will be completely gone because of osteoporosis. Other parts, the trabecular will be present, and that's why there will be pockets, because it is more prominent. The area that is more prominent in the trabecular right over here will be whitish. The area that is less, the trabecular is vanished, has been destroyed, will be more dark or black in shade or color. There will be cortical thinning right at the edge of this long bone in the femur neck, right over here. See, look at the thinness of the cortical bone mass by the periosteum. So this thinning of the bone in the vertebral area, and look at the very thin edge right over here. You know that there is cortical thinning, and that the hard bone is basically actually I have to stop you from annotating, because you cannot do that in here. So loss of trabeculae or soft bone, and then cortical thinning or hard bone, and ultimately look at that. If someone does have severe osteoporosis, there will be compression fractures right over here. As you can see, this is actually from one of the articles which said that this is actually T4, thoracic 4, T or D, dorsal spine or thoracic spine, fourth vertebrae. There is a wedge fracture right over here, as you can notice. So this is because of the osteoporosis. Now, there is many things going on in this pelvis X-ray, but probably you notice two very, very glaring things. One, that there is actually fracture in the pubic bone, fracture in the left pubic bone. This is left, this side is left and this side is right, as when you are reading it, because of the patient's PPA view. So this is the left side of the pelvis, and there is a fracture to it on the left side. Also look at the impaction. Look at the impaction of the femoral head of the right side within the acetabular cavity. That's why the complete head is whitish in structure, and the acetabular capsule, labrum, is completely eroded, degraded, debrided off. Everything is gone right over here, and you can see that this bone is impacted or pushed in that acetabulum. And there are many other things that I can see, but for the purposes of osteoporosis, this is unfortunately completely dark ischial ramus, the pubic area completely dark, suggesting that probably that there is huge osteoporosis. And this is actually a let me check, 57-year-old post-menopausal individual. This is the x-ray of a 57-year-old post-menopausal individual. That's a look at over here. What is this area? This is probably that the individual had filled up bladder, and that's what it is. The impression is showing up urine or fluid in there in the pelvic area. All right, next, fractures. All right, under fractures, again, we are not talking of like comminuted avulsion fractures, oblique fractures, transverse fractures. Then there are so many other spiral fractures. We are not talking about that. This is not an orthopedics 101 class. This is just fracture. We'll talk about very briefly as to overview what you usually come across in your hospital setting or clinic, outpatient department. So alignment, is it undisplaced or displaced? Simply. And why I did put stress fracture, because this probably you have come across either in commonly in osteoporosis for neck femur fracture, or in spinal, that is osteoporosis in wedge fracture that we just saw. So that could be due to abnormal stresses. Also in athletes, we have metatarsal, like MT5, MT2, MT3 metatarsal head fracture, very, very common in runners, in ultra distance marathon runners, very, very common, right? You know that. Also in runners or in cyclists, they have tibial fracture, fibula is involved, shin bone pain, and ultimately that shin bone pain leads to fracture or stress fracture of the tibia. Maybe fibula can also be involved. Now, from this slide or this picked x-ray slides, what are we trying to look at? Undisplaced, this one right over here on my left, and in the middle over here, this is also undisplaced, but two different types of undisplaced fracture. This undisplaced fracture is essentially, as you can see, a neck femur fracture. A neck femur fracture where the neck of the femur is impacted into the ball or head of the femur. Impacted. Look at this. How would you know it is impacted? Very, very important for you to note. Look at my arrow. Look at the cursor right over here. This black line from one end to the other shows that there is a fracture. But how do you know it is impacted and not just simple fracture? Look at the white sclerotic plaque right by the side, either side of the black line. The white sclerotic plaque on either side of the black line makes us understand that it has actually pushed in, making that fracture site completely smashed or completely within the joint. Within the joint, it's within the fracture site itself. And the head is also pushed. Look at over here. It is completely pushed within the acetabular walls or cavities right over here. And over here, probably it is difficult for you to notice, but with a keen eye, sense of eye, you will be able to. Look at right this dark line passing through, faint dark line from here to here. Faint dark line, right? Follow my cursor right over here. This is an undisplaced intertrochanteric fracture. From the lesser trochanter to the greater trochanter, this line in extending, and that is intertrochanteric fracture. Remember, since this is so faint line, it is possible, it is highly likely that this is just a undisplaced crack fracture. This is a undisplaced impacted fracture. This is an undisplaced crack fracture. So there is just a crack and nothing else is going on. So it's not that complex. And on the contrary, what's there in the middle? It is a displaced fracture. It's a similar neck femur fracture where the neck is completely superior and posterior. Superior and posteriorly rotated. It translated superiorly and rotated posteriorly, as you can clearly note. How do you know it is superior? Look at this neck femur line. It is way higher than that of the acetabular line. Way higher than that of the acetabular line. How do I know it is posteriorly rotated? Here, I hardly am able to see greater trochanter properly. Here, look at the beautiful greater trochanter. So if the greater trochanter, if the femur is rotated posteriorly, the greater trochanter comes anteriorly, and that is exactly what you are seeing in your X-ray view. Now, over here, this is essentially nothing but a stress fracture of the metatarsal 2 or second metatarsal, and as you note that this is nothing but a fracture site right over here, and that is pretty easy to estimate and evaluate. All right, so types of displays. We talked about types of undisplaced. Very basic. Again, there are many other types of undisplaced, but this is the commonest one you will see. Impacted and just hairline crack fracture, undisplaced. Displaced can be minimal, neck of your humerus fracture, minimal. There is hardly any shift of the shaft of the humerus from the ball of the humeral head. There is moderate amount of shift of the humeral head from the shaft of the humerus, and this is nothing but the supracondyle of the humerus, supracondyle of the elbow joint. This is displaced, markedly this is displaced. Again, this is just displaced fracture, okay, not completely separated fracture, so partial fracture, but it is again markedly displaced, leading to minimal, moderate, and marked type of displacement fracture. Again, there are many other types, but these three are the most commonest type that you will come across. Some atypical variations. Here, right, you notice ankylosing spondylosis or spondylitis. Spondylitis is probably a wrong way or word to say, but ankylosing spondylosis. So over here is a bamboo spine, and you can see the spinous processes are completely fused together and forming like a bamboo trunk. Here is rheumatoid arthritis of the hand or metacarpophalangeal joint. Look at the metacarpophalangeal joint. The more lateral you go, the more, sorry, if it's anatomical, then the more medial you go, there is not much of displacement over here. Here you have subluxation. Here for your little finger, you have complete dislocation of the metatarsals from the phalanges, So as you go from lateral to medial, medial to lateral, no, I am kind of rotating. So from lateral to medial, so first thing is right. Then anatomically, I am saying anatomically, there the pinky, this is the little finger, that is completely dislocated from no subluxation to complete dislocation and a little bit of subluxation over here. And over here you can see gout. Gout is nothing but these are the spots of uric acid crystals. Uric acid crystals right over here. Deposition of uric acid, big node in the uric acid over here. And this essentially tells us that this person is suffering from gout. Obviously, you will take other medical diagnosis. This is not the only X-ray that you are looking at. You will take medical history, other diagnostic features, blood test, and your own assessment and evaluation tools that you do from ROM to muscle testing and rest of the stuff to come to a conclusion of the diagnosis, right? All right. So now we are coming to the last section. So already we are close to 1 hour. We started around 9:15. Now it's about 10:15 or your 10:45, past 10:45. So bear with me another 15 minutes and we should be done by that time. So we'll talk about normal cervical spine versus pathological cervical spine. So what does this show you? Normal cervical spine. This is actually a 37-year-old female with no pathology. One normal right over here on the left X-ray, 37-year-old female, no pathology. Versus this guy is 74-year-old male, which has, what do you see right over here? Listhesis or anterolisthesis of C4 over C5. Of C4 over C5. There the normal lordosis, this curvature is gone, right? Normal lordosis is gone. There is multiple degenerative changes. Look at the facet joints. Over here, kind of normal. No facet joints itself. The facet joint completely closed down at C4, C5, C6 area. Obviously, this will lead to huge amount of impingement and radicular pain, right? And then there will be obviously osteophytic lippings, as you can see, lots and lots of osteophytes right over here. Look at that. lots and lots of osteophytes. So this is a very simplistic way of evaluating a pathological cervical spine versus a normal. Obviously, you can go in to check for rotations, check for how much slippage in terms of degrees, in terms of millimeters, with the help of your ruler and your measurement tape. But we are not going into there in terms of measuring it mathematically. So the very first thing that you would certainly notice, losses in lordosis, then you have osteophytic lippings, there is anterolisthesis and the facet joints. Always take a look at the facet joints and the foramina, facet joints and the neural foramina. Take a look at that in terms of any spinal pathology that you are evaluating. Next, normal spine. All right. In the book that I am referring to, this said it is normal, but do you think it is normal? I don't see any, honestly, a normal, spinal lordosis. To me, I don't think it is normal, but normal could be just because someone is not showing any sign and symptoms, then the patient is normal. So this patient could also have no sign and symptoms, and that's why it's normal. Not just because someone has flattened curve or there is no lumbar lordosis and no other symptoms is present is abnormal or pathological. It's not that. Someone who has leading normal life with no detriments in activities of daily living, that is also normal. Now, in the case of pathological, so one thing, this normal is 19-year-old male, obviously normal. And in this case, it's a middle-aged male with spondylolisthesis of L5 over S1. Spondylolisthesis, and possibly, if I am gauging it correctly, it's probably grade 1 listhesis or anterolisthesis. We usually call listhesis and not anterolisthesis, but for retrolisthesis, we have to call retrolisthesis because that is slightly rare. Listhesis. All right. So what I talked about in pathology is basically there is, losses in glenohumeral joint. Losses in the, listhesis of L5 over S1. There is, you can see, the disc height is actually reduced. The intervertebral disc height between L4, L5 is reduced. The disc height also under L5, S1 is reduced too. And the foramina over L4, L5 and L5, S1 is reduced. Now, as I said earlier, when the mic was muted, is two things are very, very important for you to note. Please write it down. Three things. First is you need to compare the vertebral body height with above and below vertebrae. You need to compare intervertebral disc heights above and below. You need to compare the foraminal diameter above and below. Three things: vertebral body height, intervertebral disc height, and foraminal diameter, either anteroposterior or supero-inferior. So these are the three things that you need to eyeball by visualization, compare. And in this X-ray, pathological X-ray, the intervertebral disc height is narrowed between L4, L5, L5, S1. The foraminal is also narrowed or shortened between L4, L5, L5, S1. So these two things are very evident because there is a listhesis of L5 over S1. Okay. All right. So we were talking about shoulder joint and why the shoulder joint X-ray is different than this one or this one. Because this is a video fluoroscopy. So it's a very, it's a digital form of X-ray. So a digital form of X-ray gives very crisp, clear borders, very, very nice way of analyzing and evaluating, bone edges, soft tissues present or not. Even you can check out these lung areas or lung tissues where actually air is not going. There is not much of perfusion going on within the lungs. That's why it's so dark right over here. And that's why it's so white right over here. So you can actually notice the beautiful rib cage right over here also. And this is normal condition. In the pathological area, in the pathological framework, you can see the glenohumeral joint right over here has basically obliterated the joint space. There is loss of glenohumeral joint space. There is hypertrophy of the acromioclavicular joint. Look at the clavicular head. There is like a fanning. It has flattened. The clavicular head has flattened. It has to be rounded, as you have seen in anatomy, right? But this clavicular head is flattened, telling me that the joint has hypertrophy. Look at the acromion border or edge or the corner. There are osteophytic changes, osteophytes hanging in there. So making it more hooked, and more hooked the acromion is, it is for sure that there is evidence of your subacromial impingement or anterior shoulder pain and pathology. So please be aware of, acromion position, the subacromial space, the glenohumeral joint space, and the AC joint in a shoulder pathology. So these are the key features that you need to be aware of. All right. So again, someone is again talking, so please mute their mic. Apologize for that. So I want to do it as soon as possible. Close it. I know it's getting late for all of you. Elbow joint, normal versus pathological. So elbow joint on the right is normal, on the left is pathological, and you can see that there is fracture of the olecranon process right over here, which is undisplaced, and you have fracture of the, basically you have a displaced fracture of the proximal ulna. You have displaced fracture of the proximal ulna in this kind of x-ray that you can see. Otherwise, rest of the structure is fairly normal and not a problem. This guy was, very young adult, and because of an outstretched arm fall, he had a fracture in the proximal case of ulna. Hip joint, normal versus pathological. Again, this is very, very generic, no fracture involved. This is a normal hip joint x-ray versus pathological. You can actually see that the the femoral head is jammed in acetabulum. Look at the sclerotic plaques. Look at the head of the x-ray, head of the femoral head, which essentially has less blood supply, could lead to avascular necrosis. Possibly there is avascular necrosis, but hard to predict through an x-ray, and that's why it's extremely white in color or discolored completely. And there could be a fracture line I am seeing right over here. Again, with this x-ray, I am not sure. I probably need an MR scan to really hone in to understand if there is any intertrochanteric fracture present or not. Other than that, that's basically I can see. And obviously you can notice a little bit of sclerosis, cortical thinning right across here, cortical thinning right around the neck femur line. All right. Again, please don't annotate, because again you are annotating on my screen. So lastly, knee joint, normal versus pathological. This is probably the most common things that you come across. Obviously, as you can see, there is huge amount of OA on the pathological knee. There is loss of medial joint, completely sclerosis and osteophytic changes. There is hardly any space in the medial cartilage. There will be cartilage erosion. There will be certainly amount of capsular, the capsule completely will be debrided off right over here. Look at the peaks in front. There is osteophytes actually on the peaks, which makes you know that when the patient will bend their knee joint, there will be huge amount of pain. There is abnormal increase in density right across here, abnormal increase in density, which means abnormal bone growth. Too much pressure creating abnormal bone growth right around the femoral condyle, right over here. So there are many different ways of explaining and interpreting x-rays. I can interpret an x-ray one way, you can interpret an x-ray a little bit different, but the foundational skills and knowledge are same. What is the alignment? If there is any cortical bone mass loss, osteoporosis loss, cortical thinning present or not, if there is air within the epiphysis of the bone or not, how is the joint space, if the two condyles of the bones are aligned or not, and if there is any abnormal bone growth present or not. So these 4 or 5 factors is what we most generally come across and see in our clinical setting. All right, so without further ado, so what is the take home message when you go over the video one more time, or you want to check the content and you are forgetting something? Take a look at this. Go over the bone cross section to understand, go over the color coding overview again to understand it in depth. Go over the first x-ray that is in the Dr. Imran has already sent you across, right? Then you go in for systematic reading, how you want to ABCs of reading, chiropractic spinal evaluation, what do you find in osteoporosis and fractures, and then normal versus pathological x-rays for different joint space. All right, these are the resources that I have used. I will tell you, these 2 books are immensely important and wonderful. Fundamentals of Musculoskeletal Imaging by McInnes and Imaging in Rehabilitation by Malone, Hazel and Gray, or Hazel and Gray. These 2 books are very, very, strong, will make you very strong in radiology and other imaging in terms of rehabilitation, in rehabilitation of skeletal science. This is my contact information. You can contact me through Facebook, Instagram, or Twitter, or even WhatsApp. You can do that. This is my email. This is my website, and you can subscribe to my YouTube channel for more videos like this. And that will be helpful for both you and me to create more constructive content for you all. All right. So the session is open for question and answer.